Welcome back, everybody, to the Overruns Journal Club. Ed Bowder and Dan Schwester on the
It's
Overruns
Magic
YouTube.
Monday.
Magic Monday. Today, we're going to talk about a study from Finland because we are a worldly group over here at the Overrun. So we're going to jump right into it, and we're going to talk about this Finnish study that came out that it talked about non-urgent EMS conveyance to the ED during night shift. And this is a pilot study done in Southwest Finland. So the first thing to talk about, Danny and I, we've done some night shifts in our careers. Certainly, at least anecdotally, the patient population is different at night.
Yes, very a lot different from the day shift. A lot different. I always found it was less people, more acuity, but looking at this study, maybe it's not.
I tend to think that's right, and I used to, I would die on the hill of, night shift has higher acuity patients, maybe less patient, lower volume, higher acuity.
Right.
And even when I was a medic student, I would argue, because I worked night shift doing BLS, and I would argue like I should do night shift on the medic truck because I'll see sicker patients, right? I won't see the day shift standard monitor and transport of a 95-year-old who has a headache. But you're
altered labs.
Right, exactly.
From the skilled nursing facility.
Critical abnormal labs on a Friday night. But what was interesting about reading this study, and we know there's certain populations that spend more time in the ER, right? Abdominal pains have something like an 80% 24-hour admit rate. There's a whole bunch of stuff. But I think it's often argued, I shouldn't say always, that, night shift has the same urgency as day shift. And I think intellectually that's probably true. But this study kind of tells us that we're wrong. So this is coming out of Finland. This is August of 23 out of BMC Emergency Medicine. This is Cosby et al. So what they did was they did a retrospective analysis on a group of patients, which ended up being about 117 patients. Now, that 117 is a little underpowered. I don't love that number. But again, this is in Finland. This is in 2 counties. So the population
only 2 centers. We don't know what their we don't know what their total population is, total frequency of visits. There's a lot that's not here. Is this a really sleepy, small facility, community-based facility, or is it a tertiary facility? It doesn't really get into.
And some of the population data is elucidated in this study, but really the stuff that we wanted to talk about essentially was the patient split. About 50% of the patients were between 18 and 69, and the other 50% were over the age of 70. In this study, they looked at 73.5% of the patients received neither medical treatment nor had diagnostic tests taken before the morning. Let's put that in our back pocket. We're going to come back to it. And patients over 70 years old received more medications and had more diagnostic tests than younger patients, which I think stands to reason. I didn't think that was very surprising. So the conclusion of this, and again, this is going through the abstract, we're going to talk about the paper. Some of the low acuity patients could be non-conveyed or referred to alternative pathways of care to avoid impolitic use of emergency medical service and to reduce the workload of emergency departments. Further research is needed to ensure patient safety for those who are not conveyed at night. Now, again, I like that it says further study is required. That's usually every study. But let's start getting into some of the data here, Dan, because the patients that were seen, I thought were pretty interesting.
Yeah, it really was kind of an interesting thing. I mean, I was kind of surprised, Finland, Scandinavian country, very high quality of life. They have what you call a socialized medical system. Where it's taxpayer supported. Basically, nobody really pays for a lot of stuff. Different model than the U.S., but you saw the same patients. What really struck me was the high number of senior citizens. Over 50% of their cases were the elderly population. And a lot of the same complaints that they go on at night or during their shift is a lot of the same stuff we saw. So maybe we're not so different after all.
We're all just the same, guys. But I do think that's right. It's difficult to look at a cross section of a population in a study and sort of move it into or extrapolate it to your population, right? And of course, the first response is going to be, well, this was in Finland and this was in 2 counties, and my town's not like that. My city's not like that. And that may be true, but again, based off of this research here, We have these ambulances that were dispatched. They were used 11 different codes. The most common were patient transport, decrease in common general condition, abdominal pain, fall, and mental disorder. I think mental disorder stands to reason, right? You're working night shift. I think most mental emergencies probably happen at night. Certainly not all. But I also tend to think that patient transport and decrease in common general condition could probably be lumped into one category, right? That to me, that sounds like your skilled nursing facility call at
That smells
11 a.m.
catch-all to me. Like, we don't know what to do with this person. They're calling the emergency line. Send somebody out there and see what the story is.
Yeah. And I think that's kind of the interesting thing. The abdominal pain at 15%, I think is kind of fascinating. That felt low to me. But again, that's just me. So again, 73.5% of these patients. Now, again, this is only 86 out of 117, but they did not receive any medical treatment or diagnostic tests. And that's the end of that story. That's the end of that sentence. Native x-rays were taken on 6% of the patients. CAT scans were taken on 4.3, lab tests on 6.9, and 21% of the 22% almost received medications. Patients older than 70 years old received significantly more medications and had more diagnostic tests taken than younger ones. And again, you have here half of the patients with a fever, abdominal pain, and almost half with respiratory infection received some medical treatment or had some diagnostic tests taken. So after going through all that, let's go ahead and get into the discussion here, where I tend to think that if you're over the age of 70 and you present to the emergency department at any time with abdominal pain, you're going to buy a bed. Right, you're going to you're probably going to get admitted. There's way too many things that can be going wrong with an elderly patient with abdominal pain to not warrant further tests, further scans, observation, whatever. Right.
I don't think you see any elderly patient in an American ED or a British or a Australian, Finnish ED comes in with a vague abdominal complaint, doesn't look great. They're getting worked up. Let's be honest.
Sure. And again, that's the over 70 population. But I do also think in the under 70 population that when someone complains of abdominal pain, now you can make the argument that if they waited to call at night, then maybe they've been having the pain all day and it's gotten worse and all that other kind of stuff, right? But I would think that generally, clinically, under the age of 70, abdominal pain, you can, in most cases, is probably just a boo-boo tummy.
Yeah, again, something we don't study, something we don't look at statistically. Not everything is a acute abdomen, hot belly, whatever you want to call it, surgical emergency. Yeah, it's definitely possible.
So I see these numbers and I think of how systems work with patients, right? So, if you're in a hospital-based system, you might have a policy that abdominal pain over the age of 65 has to be treated by medics because they'll buy an admit, right? I'm seeing data like this. It makes it, and it's not reducing the acuity of the patient, right? It's not to imply that the patient isn't sick or that they're not having a bad time. It's a resource allocation thing, right? If you make it necessary for a medic unit to treat these patients based on whatever data you've seen, and then the patient goes to the hospital and has to wait 14 hours to get an x-ray or a CT scan, are we really providing services for those patients? Or are our services better used elsewhere?
Yeah, it's a good point. And this study seems to back it up that if the majority of these people aren't getting anything worked up, do they need to present to the emergency department? And by extrapolation, do we need an EMS unit to convey them to the hospital, or would another type of facility or mode of transport be better for them? Or get at least non-inferior, right? That's the new buzzword in medical literature.
Right, yeah. It's not better or worse than non-inferior.
Right.
I'm a big fan of suboptimal, by the way. I like the term suboptimal to describe things. I use it for everything now. Like, the New Jersey Devils played very suboptimally. The Philadelphia Eagles had a suboptimal playoff performance.
But it's interesting that in this system and in this snapshot, it really seems to scream for some sort of alternative screening process and an alternative destination process where maybe these people can be seen in clinic in the morning, or maybe they can be seen at an urgent care later in the morning, without having to present to the emergency department, take up that bed, use an EMS unit, going emergently. I don't know what they do in Finland, if they go with lights and sirens to these type of things, or they go kind of.
Yeah, certainly that the 2 minutes they're going to save using their lights going to the hospital is going to save the 10 hours for their CAT scan.
Yeah, I mean, there's. Let's be honest. We talk about risk, right? We talk about this stuff being an increased risk to the patient, increased risk to the crew. If we can avoid it, we should be using it for the people that need it. We should be avoiding it for the people that don't need it. I think it's probably, in this study, the data says it's probably safe that these younger patients don't need to present to the emergency department or can be sent down an alternate pathway. I'm not saying don't at me in the comments. Like, I'm not saying they don't get they don't get care. But what do they need screening wise? Do they need a more powerful screening tool? Do they need some place where they can go, where they could drop in or have an Uber Lyft type of, conveyance? Anything to have that ambulance going, lights and sirens to the house, carrying them out in the street, putting them in the truck, taking them to the hospital. We know that this model is putting stress on our clinicians. It's putting stress on our systems. It's also putting stress on the emergency departments, because these complaints pile up and they are less able to handle that critical patient that comes through the door, that really sick person, or that dangerous presenting complaint that needs a lot of attention.
And I think the alternate destination conversation is interesting to me. And certainly there's laws and legislations that are going to have to be changed in order to allow it. But I feel like every time we have this alternate destination conversation, we act like it's a new thing. And when Vancouver did the Olympics in 2010, they were sending patients to alternate destinations because their call volume went up 20% during the Olympics.
Oh yeah.
So they would have people on the phone doing like 911 triage, where are you calling because you're having an emergency, or is your prescription empty and you need a refill? Because we can do that over the phone. You don't have to go to the hospital for that. Right. So now, almost 15 years later, we're still having well, do we think that maybe I can take this patient to an urgent care or to a sled or to wherever else? And what's frustrating to me is, going into the ER, seeing people hanging off the rafters, waiting to be seen, and with varying degrees of illness, and subsequently what ends up happening is, we'll bring in a really sick patient, and then the really sick patients in hospitals get priority. And I do think that's the way it should be. But now you've got someone who maybe might have a chronic disease that isn't being well managed, who is sitting on the wall for 20 minutes or 20 hours. It might be waiting to get their script refilled. But if you've got someone who's got a really brittle illness, they need that medicine right now. So the reason that I found and went through the study and wanted to talk about it is I wanted to kind of bring up the conversation of resource allocation and destination allocation. I don't think that having your ALS units, whether you're a hospital-based system or a fire-based system or police or municipal or whatever, if you have in our state, we have a 2-tiered system. So it's easy to have this kind of conversation, right? If you're in a 1-tiered system, it's a little bit more difficult. But in a system like ours, if you're having the medic units treat abdominal pain over the age of 65 or over the age of 70, because one day there might be someone who has a AAA and you're worried that you might get sued, at what point do we say that we've stopped practicing clinical medicine and we've just started following legal policy? Do you know what I'm saying? At some point, it's no longer practicing medicine. At some point, it's just,
I'm sure there are people that would have that debate with us.
Probably.
I think you're right to a point. I think we desperately need to have a discussion in this country and other countries about what do we want emergency care to be, and what do we want it to be there for, and what can we depend on, what can patients access themselves without our assistance. And that's a real issue. And going back to the alternate destination thing, I think about airlines. When you're up in the air and they're like, "Oh, is there a medical provider or a physician on the plane?" Um, one of the things
I like how you said that more calmly than anyone's ever said it on a plane.
well,
real quick. Anyone do medicine here? It's not a big deal. I just want to make sure. Just checking. Just taking a head count. Taking your temperature on it.
For sure. But one of the things that I found out that was interesting, because just on an off chance, I was looking through things and I got on this topic and I got down this rabbit hole. It's really interesting because in-flight emergencies happen a fair amount of times. There is a lot of medical people, a lot of clinicians, a lot of physicians on planes on a regular basis. Not all of those patients get admitted, and diverting a flight to an emergency field is a buttload of money. It costs a fortune to do that.
Yeah.
And the airlines have really set up a system where they will do anything to try to avoid diverting that flight. And they have found that statistically, most people don't need it. Most people who are seen in the hospital after an in-flight emergency are released. The data tends to suggest that most of the complaints are very benign in nature. The quote-unquote boo-boo tummy that you said earlier.
I'm going to make an ICD-10 code for boo-boo tummy. One day, you'll see.
Sure.
It'll be out there.
But it's a really, if you get a chance to listen to somebody talk about these things, about in-flight emergencies and what actually happens, everybody thinks it's like, oh, we're delivering babies and we're doing cardiac arrests at 35,000 feet. That doesn't happen except in very, very rare circumstances. So
imagine working an arrest in an airplane bathroom. It's a nightmare to work an arrest in a house bathroom.
Look, the one that everybody remembers is Carrie Fisher. She had a cardiac event, she went down on the plane, they work it, but very, very few and far between, right? A lot of from what I was listening to the speaker, a lot of vasovagal stuff, a lot of abdominal complaints that turned out to be benign, minor things like that. And they have a system in place where they will put you on the phone with an emergency physician whose specific job is to listen for these calls and help you decide what you need to use in the kit, what the captain needs to do, and do we need to go to another airfield, or can we just get to our destination with you watching this person? If the airlines can do this, and we love aviation, we love bringing aviation into medicine, right? Why can't freaking do this for emergency calls?
I agree with you. I'm perfectly comfortable with all the doors staying on my ambulance and my SUV. As long as my vehicles aren't made by Boeing, I'm perfully comfortable with it.
Sorry, Boeing. You had a rough couple of weeks. We'll give it to you.
But I do think all that's true, and and again, this talk of alternative destinations, and what we're talking about with these patients with minor complaints is we're not talking about your generic nausea patient who gets a line, some fluid, and 4 to 8 milligrams of Zofran, depending on your protocol, and then isn't treated in the ER. That's not who we're talking about. We're talking about your patient who, imagine a patient who presents with, say, gas in the epigastrium, right? That's abdominal pain. It's going to have to be ruled out as an MI in most protocols and blah, blah. Yet at night, they're often not even seen, right? In this particular study for a while.
For a while.
And I know that we're going to get feedback where it's going to be like, well, again, it's a Finnish system. America is better at doing that. And I kind of think that we almost overcorrect a little bit. Right. So if the Finnish study is showing these populations where, 29% are transports, 15% are abdominal pains, I feel like it's like, okay, so they don't ever get monitored or they don't get seen or they haven't been assessed in, 10 hours, whatever. In the United States, I feel like a lot of times we overcorrect for that, right? Where 50% of abdominal pain might get seen within a half hour because we want to rule out any other serious complaint, right? Now, that might be the
or
case.
we want to meet metrics.
Right. And that might be the case. We don't have the data up in front of us. It's just a fun conversation. But, in those settings, are we over triaging these patients because of our fear of litigation, where
Yes.
some European countries have a little bit more freedom, I guess, a little bit more access to practice because of a universalized system.
Nobody
that's much
got
less
more
litigious.
freedom than the U.S. of A., boy.
Over here, we practice freedom medicine. That's what I do.
But there's something to be said for this. And, I know we're kind of having some fun with this, but getting back to the topic, this is a system where you don't pay for your medical care by and large, or you pay a very small thing. It comes out of your taxes. You don't see it pre-tax, post-tax, whatever. Yeah. You're going to present to the ED, and in these two hospitals, in this snapshot of their system, the majority of those patients were not seen on the night shift.
Yeah. And that's really all it comes down to.
There was no bad outcomes. Nobody said, there's nothing in this paper that says.
Yeah, it's not, they weren't seen and then everyone died.
Exactly. There's no central
the mortality in this study was 100%.
Right. There was no, yeah. It was, nobody's saying that. We're saying that a lot of these non-urgent or these non-emergent complaints probably can be seen at lower acuity on a more favorable time schedule that is more efficient to help the system.
Or be seen by telemedicine, or have, be referred to your general practitioner. And there's a lot of interesting alternative destination options that I think need to be explored.
The system's collapsing. We have to have these talks, and we need papers like this to show us data that says, look, you're 52 years old, you have a boo-boo tummy. You can wait till 8 o'clock in the morning
and see your doctor.
Take this and see the urgent care at 8 a.m. If this happens, call back, and we will take you to the emergency department.
So, and that's one of the most important catches to this before we get out of here is it's also important to recognize that what we're suggesting, what we're talking about, is not binary, right? It's not you either go to the hospital or you don't, and then it's it, right? If you assess a patient and they present these ways that can be either left at home or can be deferred to a different facility, that's great. They can call back 3 minutes later because they're just not feeling great. And also the patients will have the prerogative to say, I would just feel better if I went to the hospital, right? That's a different conversation. The patient deciding like, I would feel more comfortable if I just went and go get seen. Fine. That's a different conversation, right? This is just what the data suggests to the patients that went to the hospital. But I think it's interesting. I think it's important. And I think we have to kind of continue the conversation on alternative destinations and, different therapies for patients that call 911. But let us know what you guys think. Comment down below, like and subscribe, listen to the podcast, do all the other stuff. I'm Ed Bowder. That's Dan Schwester, and we will talk to you all next week.
See you later.